Treat to target, and really the title was, how do we measure it, what is our target, and I've sort of just changed the title a little bit to Does It Matter? And I have no disclosures for this talk. I have another talk tomorrow on small molecules and rheumatoid arthritis, and I'll have a disclosure slide that'll take up the whole slide. So what is T2T, or treat to target? And there was a nice editorial in Arthritis and Rheumatology Now last year by Dan Solomon and colleagues. And basically it's a treatment strategy in which the clinician treats the patient aggressively enough to reach and maintain explicitly specified and sequentially measured goals such as remission or low disease activity. So how do you do this? Basically you select a target, you do a regular assessment of disease activity utilizing a validated outcome measure, you determine the appropriate frequency of the evaluation, and you act on that evaluation to modify the treatment to achieve the goal. So where did this come from? And how do we get this into rheumatology? Clearly, other internal medicine disciplines have been using a treat-to-target algorithm, certainly in the lipid field, hypertension and diabetes mellitus. And again, and I'll show you an editorial that sort of jump-started this in 2010 in ARD, but it's not as straightforward as you might believe. There's certainly in all of these disciplines, there's not a consensus on what the target should be. Clearly, improving blood pressure, improving lipids does improve cardiovascular risk. Diabetes, there are studies that suggest treating to a hemoglobin A1C are helpful and then also are harmful. So it's not a clear consensus. This is work from Scott Grundy, who is at the UT Southwestern, and looking at the LDL cholesterol on the x-axis here, and looking for every 30 milligram per deciliter increase in LDL cholesterol using a logarithmic scale, there was about a 30% increase of coronary artery disease. So clearly a relationship which has been well vetted over the last 30 years. They, like us, like rheumatologists, frequently come out with new guidelines documents that go on for pages and pages and pages. And this is the most recent ACC, American Heart Association guideline for the management of blood cholesterol to reduce cardiovascular risk. And this, again, is one of those busy slides, which we're not going to go through. Basically talks about high and moderate intensity statin therapy, patients who are at risk, and what you might consider doing in those patients. But deep in the body of the paper, there's a statement on treat to target. And again, talks about how this strategy had been utilized for over 15 years, but actually the current clinical trial data do not indicate what the target should be. That we don't know the magnitude of the additional risk reduction that could be achieved with one target lower than another. It does not take into account the adverse events, which we don't talk about frequently when pushing people to a certain target, but the adverse events which could occur from multi-drug therapy. So in this particular guidelines document, in view of the absence of data, the approach appears less useful than it might appear. So clearly we want to reduce these levels, but we don't know exactly what the target should be. So this was the editorial in ARD, which I alluded to. Treat to target, moving from hypertension, hyperlipidemia, and diabetes to rheumatoid arthritis. So rheumatoid arthritis actually is an ideal disease to try to develop a treat to target approach. We know, and I'll show you just one set of data, and there are multiple data sets which show that disease activity is associated with reduction in quality of life and premature mortality. This is data from Ed Yellen and his group at UCSF, and this is data from the 80s and 90s in the pre-biologic era. But basically, if you take patients and stratify them by their physical function disability, the quartiles of HAQ scores, you can see that patients with greater disability and poor physical function as measured by the HAQ score have a lower survival. The mortality risk is increased. And if we can improve their physical function disability up to this area, that we could prolong their survival. And we've seen this in numerous long-term observational databases to confirm this data. Short term, there was a study from the Netherlands. A lot of this work on treat to target has come from across the pond. And again, the systems over there, certainly in the UK, where you have a consulting rheumatologist who may see the patient every 3 to 6 months, otherwise managed by a family practitioner, you know, their outcomes are not what we think we have in North America and the United States. And certainly in my practice, which has been going on since 1980, if I had a patient with active rheumatoid arthritis, I'd see them as frequently as I need to see them, every 3 to 4 weeks, or even more often if I need to get them under control. But in the Netherlands, they have a cohort of hospitals that have come together to look at targeted therapy and target DAS28 remission, DAS less than 2.6. And they've enrolled a slew of patients into this database, and they looked at their one-year data in 239 patients, and they saw that they could get almost two-thirds, 57% of patients into remission, another 16% into low disease activity. And you can see that the majority of these patients had a HAQ score less than 0.5, which is considered one of our targets as well. So clearly, being aggressive with treatment, we can improve the clinical outcomes in our patients, and hopefully long-term, this will translate into a reduction in morbidity and mortality. So we also know that if we have less joint damage and improved physical function, the patients will do better, as I've stated, and that will occur if we treat our patients early and we treat them aggressively. And again, in rheumatoid arthritis, we have data that goes back as far as this data from Lard, also from the Dutch experience, looking at patients seen from 1993 to 1995 who had a delay in therapy of 3 months after they presented to the clinic, and these were early RA patients, compared to patients from 96 to 98, also with early RA, who were treated within 2 weeks of presentation. And you can see the patients treated earlier had less progression radiographically. This is looking at the Sharp score on the y-axis, 3.5 units compared to 10 units with just a 3-month delay in therapy with drugs that were not particularly that potent, hydroxychloroquine type drugs and sulfasalazine. Now, in the new era, since 1998, when the first biologics were approved, we now can target remission. This was never something that we considered in clinic previously. I started in the area of gold and penicillamine, which is hard to say. We were early adopters of methotrexate in 1980, 81. And even with methotrexate from 81 to 98, we had a third of our patients did very well, but the other two-thirds or more continued to progress, developed deformities, disability, and inability to function in their daily activities. Certainly since 1998, it's been a lot more fun to be a rheumatologist, and we've learned that our therapies can be incredibly effective and certainly more effective in the patients that we see earlier. This was the COMET trial. Paul Emery was the first author, looking at methotrexate monotherapy versus combination from the get-go with etanercept and methotrexate in early moderate to severe rheumatoid arthritis. And just to summarize, since we have a short time for this talk today, 20 minutes or so, clearly the combination therapy with etanercept plus methotrexate, 50% of patients at the end of 52 weeks were in remission compared to 28% on methotrexate monotherapy. And in addition, the patients on combination therapy were much more likely to have no radiographic progression over a year's period of time. We have numerous databases, such as the Premier database, which also have shown the same type of phenomenon. So it became a reality after 1998 to begin to target low disease activity and target remission. We can also measure disease activity. We've always measured swollen and tender joints, and it's funny that Artie and Jack were talking about clinical trials and not seeing patients for their non-radiographic spinal arthropathies. We always thought swollen and tender counts were the most objective measure that we have in clinical trials. And what we've learned is probably the least objective measure we have in clinical trials is as people may squeeze harder to get a patient in the trial to see if they have more tenderness. They may see more swelling that goes away when the patient's on therapy. And Vibeke is in the back, who's going to talk later. She and I did some work early on that actually showed that patient-reported outcomes, pain, HAQ scores, and so forth, had a greater effect size compared to placebo. There was a higher placebo response rate with the swollen and tender joint counts, but most of the community that is in this field looking at remission and low disease activity certainly feels keeping the swollen and tender joint count in the paradigm is important. But we can look at these joint counts, we can look at acute phase reactants, we can look at patient-reported outcomes, and we now have validated composite measures that we can utilize to measure disease activity. I think everyone in this group is familiar with all of these disease assessment measures. We don't use the ACR responses in clinic. It certainly measures one point at a time. It's not a dynamic measure measuring change over time, like the DAS scores, the various variation disease activity scores. But again, all of these are available. You have the patient-reported outcomes on the bottom. The ACR, which is good at setting up committees and putting together task force. put a task force together to evaluate these various disease activity measures, and there were over 65 disease activity measures that they started with, that they evaluated. They looked at their validity, their responsiveness to change, and basically came up with these elements that any disease activity measure should have. It should reflect disease activity, it should be sensitive to change, it should discriminate between low, moderate, high disease activity and remission, and it should be feasible for use in the clinic and acceptable to rheumatologists who practice in academic or clinical centers. So in this document, they came up with 6 disease activity measures which they endorsed and basically said to rheumatologists, use what you choose to use, that these would be acceptable. And you have these patient-driven composite tools, the POS2, the RAPID-3, which look at patient global, HAQ scores, pain rating. You have the CDI, which I use in my clinic, which has MD, joint count, patient global, provider global, and remission, and does allow for remission criteria. You have the Simplified Disease Activity Index, and you have the DAS-28, which also use acute phase reactants. And these have been shown to be reliable and to discriminate change. And again, in your handout, this is the actual scoring system. How many of you rheumatologists or physician extenders measure disease activity on your patients? So it's growing. It's growing. I'll show you a little bit of data on that later. And then finally, we have the work of the ACR and EULAR subcommittee that came up with the definition of remission for clinical trials, the Boolean measurement, which is swollen and tender joint counts, patient global, CRP all less than or equal to 1, or the Simplified Disease Activity Index of less than 3.3. And for clinical practice, they remove the acute phase reactant or use the Clinical Disease Activity Index. And again, these have been widely studied. You know, the rates of actual remission with combination therapy with these more stringent definitions of remission, which are much more stringent than the DAS-28, are in the ballpark with combination therapy of 15 to 20% and with monotherapy of about 10%. And unfortunately, sustained remission is often even less than that. And then we do want to, just mention what the impact of fibromyalgia may have on these various disease activity measurements where there's a patient global rating or even a joint score. This was from a French cohort of patients that looked at the various measurements of disease activity and the individual components and looked at the impact of fibromyalgia on these scores. And you can see that for the DAS-28 and the SDI and CDI that the scores were significantly higher for patients who had fibromyalgia, and this was driven by total joint count and the patient global. So we're well aware of this. We keep trying to come up with ways to modify these questions to help us ferret this out in patients who have either other issues of secondary gain or have fibromyalgia. So the final point is structured management with low disease activity as a target has already been demonstrated to be superior to usual care. And I'll just show you a couple of examples of studies, and these should be familiar to the majority of you. So these are several of the studies which have been looking at treat to target versus usual care. And the Ticora trial I'll discuss in just a few minutes, the Camera trial, which was early RA, looking at methotrexate with computer adjustments of the dose depending on disease activity, the Finrayco study, and then Artie's already mentioned the BEST trial, and I'll just show you a couple slides on that as well, which used a DAS-44 of less than 2.4 as their target. So the Ticora trial was really where we first got started talking about looking at treatment strategy and tight control. And this was a study that was conducted around the turn of the century, 98, 99, in the UK, looking at about 110 patients who entered the trial. And you had a routine group which was seen every 3 months by a rheumatologist. They were allowed to do whatever they wanted to do, any DMARD therapy at that time, inject a joint if necessary. You had the intensive group, which was seen monthly and was started initially on therapy, and at 3 months aggressively cycled through therapies to triple therapy, and also received IM corticosteroids and had joints injected if the joints were swollen or active. And again, these people had about 1.5 years disease, 0.75% rheumatoid factor positive. What's interesting is in this era of the late 90s, they already had significant radiographic disease as measured by Sharp score. So this was the schematic of the tight control group, and this was the routine group. And again, monthly review of DAS, swollen joints injected, IM steroids given as bridge therapy during the first 3 months, and if after 3 months disease activity was still moderate based on the DAS-44, there was structured escalation of DMARD therapy. And this is just a cartoon depiction of what basically patients were treated with. Sulfasalazine at that time in Europe was the initial DMARD of choice. They were rapidly progressed to triple therapy in the intensive group. If the disease activity was persistent, steroids were added, and then cyclosporin or other DMARDs could be added at a later date. So this was the bottom line. And the bottom line is that if you looked at the EULAR responses, whether it be good response or remission, or you looked at the ACR responses, you could see that statistically significant differences were seen between those who received tight control versus those who had routine treatment by the rheumatologist. And again, at the time, I wasn't sure how much of this is a reflection of the way things were practice was conducted in the UK, and I think a large part of that was compared to what we did in North America. But I think it's important now that we've set up these targets, these thresholds to hit, to try to push us or prod us to pay more attention to our patients to make sure that we are treating them aggressively enough to allow them an option for good clinical outcomes. The cost here was really no difference between the two groups. There were less inpatient hospitalizations in the intensive group, and although there was more outpatient care provided, and that's shown here. Adverse events in this database were no different between the two groups. And actually, in most of the treat-to-target trials, the safety issues really were no different between treat-to-target and the routine treatment, except for the camera trial, which intensively pushed methotrexate or cyclosporin. There were more dropouts in the intensively treated group. So I already briefly showed this slide from the BEST trial, which the 10-year data should be released in publication very shortly. Was looking at early rheumatoid arthritis, targeting a DAS-44 of less than 2.4, monitored every 3 months, and it was a strategy trial, looking at monotherapy initially, step-up therapy, step-down therapy from steroids and sulfasalazine methotrexate, or starting with the biologic initially. Throughout the 10 years of the trial, many of the patients progressed to combination therapy or progressed to biologics plus methotrexate. And again, what it shows is that with this monitoring disease activity, changing your strategy, that you can get very significant improvements that are maintained in the majority of patients. This is the 5-year data. I already showed you the 10-year data. Looking at the HAQ score, the drug-free remission numbers were really not that different between 5 and 10 years, and about half of the patients achieved remission, albeit with a little bit less radiographic progression in the patients who were treated with steroids initially or with infliximab. And just one point that already brought up about this 15% number of patients with remission with withdrawal therapy, Jonathan may bring it up as well. But if you go back to data from the 80s and 90s, and you follow these patients and patients that are taken off therapy, there are trials back then, we always seem to see 10 or 15% of patients who can maintain in remission. And again, generally these are the seronegative patients or the patients who were in deep remission. So based on all of this data, EULAR put a subcommittee together, chaired by Joseph Smolin, and there was a couple Yanks on here, Gabowski and Keystone, but mainly our colleagues from across the pond, and wrote a paper on where do we stand with treat to target and made recommendations. And this is a busy slide, but it's in your handout, and they put overarching principles which that, treat to target should be a shared decision between the patient and the rheumatologist. The goal of treating the patient with RA is to maximize long-term health-related quality of life. Getting rid of inflammation is the most important way to achieve these goals, and we should monitor disease activity. And they felt that the target should be clinical remission, except in some cases it's okay if you shoot for low disease activity. So clearly we're faced with this decision every day in the clinic. If you see a 35-year-old patient with rheumatoid arthritis otherwise healthy, you will be aggressive and try to induce remission. You see an 82-year-old person with COPD, diabetes, congestive heart failure, you're going to be less excited about cycling through therapies and being more aggressive to try to achieve remission, and maybe therapy may be palliative, or maybe the best you can do is low disease activity. So we have to be realistic in our expectations, but again, I think that having a target to think about keeps us on our toes as far as trying to be aggressive and helpful for our patient. There's actually a website that you can go to where there's very little on the website that came out originally when EULAR was behind this, and I think this had sponsorship by pharma, which I'm not sure that sponsorship exists at this point, so really there's not much there, but there is some educational materials both for professionals as well as their patients. So what about adherence to treat the strategy? What do we know? Do people continue to do this? So going back to the DREAM remission induction cohort, which is the group in the Netherlands of these 6 hospitals, they basically cherry-picked 100 patients who were in their system and who had DAS28 scores looked at, who had at least 6 months of follow-up. And what they found, that adherence was quite good, that the physicians were measuring, or the physician extenders were measuring disease DAS28 in almost all the patients. 88% had DAS28 measured every 3 months. In the patients not in remission, 58% had their therapy advanced. Adherence to the treatment advice occurred in 70% of the patients. And as you would expect, the primary reasons for non-adherence were side effects concerns, patient's wish, and the physician felt they were in clinical remission. This was an abstract from ACR looking at a cohort of clinical groups that have gotten together in the States and basically asked a very simple question. Do you measure disease activity? And this was the response they got. 25% did not. About 18% measured DAS28, 20% CDI. Most common was the RAPID-3, the patient-reported outcome, which Ted Pink has promoted for many years. So this is growing, but certainly has been a slow fight to get this done. Now, one of the things that has accelerated our desire to measure disease activity, other than wanting to help our patients, was the physician quality reporting system that CMS put into place that we all have to abide by. And if you'll see here, number 177 is the percentage of patients 18 years and older, the diagnosis of rheumatoid arthritis who have an assessment and classification of their disease activity within 12 months. So it is a disease activity, it is one of the criteria we can use when we report to the PQRS system of CNS to achieve this threshold. They used to pay us a pittance, now they take money from us if we don't meet these thresholds. So Solomon and his group, Dan, looked at the results of the various treat-to-target studies that were out there. The targets have been reached by about a third, 82% of patients. More patients achieved target in the intervention cohorts than standard of care. Overall, the safety outcomes were similar. Radiographic outcomes were improved. Intervention groups were evaluated. There was limited cost data. Basically, I showed it to you in the TICORA trial. And then their research agenda, is there one or more effective treat-to-target strategy? Should the target always be the same in all patients? Is long-term treat-to-target associated with improved physical function, reduced morbidity and mortality? What about the side effects, and what are the economic costs of being more aggressive, doing more testing, and so forth in the clinic? And then, again, I already showed you the algorithm for the preliminary recommendations as far as the treatment of RA therapy. In the body of that paper, they have strongly recommend using a treat-to-target therapy strategy rather than a non-targeted approach in early RA and established RA. Ideal target should be either low disease activity or remission. And then to finish up, this is from our e-records, our medical records. This is not one of my better patients. I'm sorry I have to show you this here, but this is my clinical disease activity index that I have in my medical record note that I've done that day for the patient. And this is one of my handful of RA patients that I've tried everything I know to do and has failed. And you can see the CDI score of 64, which is quite high. So that's somewhat of a quick run-through, 20-minute review of the field, and I'll be happy to entertain any questions if there are any.